so the countertop, the island will be that color.
There we go.
There we go.
Okay, it is 5 p.m. We're going to go ahead and get started. So welcome to everybody that's out here and anybody that is tuning in to us tonight. It is 02/20/2020. So that's one of those dates, right, that we need to remember. So we'll start out with the invocation. Can I ask Pastor Romero?
Good afternoon. Let's praise. Heavenly Father, I thank you for each and every one of us who are gathered today in this place, for the men and the women who work hard to well-being and help our community. Holy Spirit, we ask you to lead this meeting. I ask you for your wisdom in making decisions and ask you to lead them for each project they may have, and also pray for unity and love among themselves. I bless every person who volunteered. I bless Indian River County Hospital District members. I bless every person who contributes financially. I bless every person who worked hard to make Indian River County better. I bless their family, Lord. I declare open heaven for Indian River County. In Jesus we pray. Amen.
Amen.
Thank you so much.
Thank you.
very much.
God bless you.
Nice. Very
Appreciate it.
nice.
Thank you so much. Michael?
Yes.
Thank you. We'll begin with the consent agenda. Can I hear a move for the approval of the regular monthly meeting minutes dated January 16th and a February disbursement of,
$1,186,012.41.
can I hear a move?
So move.
Second?
Second.
All in favor?
Aye.
Good. Just an update on a couple things going around the community to make sure that everybody knows that. The United Against Poverty Center is now open. The clinic is now open. That's being run by Treasure Coast Community Health. So it is there Monday through Friday. If you haven't been there, you should stop in and see it. It's really quite an impressive building. And for the use of the community, I will say that. For anybody who needs to use it. They have a lot of teaching spaces and open spaces. So, couple updates about our hospital, Cleveland Clinic. We're just awarded, this is Cleveland Clinic as a system, for the 10th year in a row. They were awarded the Ethics Award, which were out of 13,000 companies that are looked at. About 213 of them actually get an award, and this is the 10th year in award. So it's nice to know we're doing business with a highly ethical company, too. They did just raise their initial rate to $13 an hour for all the people that work there, which is a really nice statement about caring for their caregivers that work there. So once again, we're very happy to have them here. The Community Needs Assessment, which is being done by the Community Foundation and the United Way and the Health Department and others, will be completed by the end of this month. So we're kind of anxious to see what's going to happen with that. But spoiler alert, the first biggest need that they have found so far, obviously, in the community is mental health. So we kind of knew that was coming. And then yesterday, there was a meeting where Indian River County received the designation of an age-friendly community, which is just the beginning to be able to really understand what that really means and where we're really going. But it's nice to know we're on the track of doing that. So all good stuff going on in the community. With that, I'll move to District Council report. Jennifer?
Thank you, Madam Chair. As we discussed at our chairman's meeting yesterday, I have worked this past month with our district executive director to review the bylaws for some of our amendments and suggested updates, which you all reviewed and will vote on next month formally to approve and adopt. As always, I've reviewed all of the monthly meeting minutes and special meeting minutes from the past month, have responded to questions that any of you have had for me, and then every year in this time of year, I receive an annual auditor's letter that I respond to on behalf of the district as your counsel. And then also I reviewed the annual deadlines and deliverables at the beginning of the year due to the district under the lease that we have with Cleveland Clinic, Indian River, and sent correspondence to the district office summarizing that. If anyone has any other questions, I'd be happy to take those.
Okay, moving on to the financial statement review. Mr. Jones.
Well, as you know, we're in great financial shape. Very sound. Right now, we have about $13 million in the bank. Tonight, we spent about $1.2 million. We've got about 8 months left in our fiscal year, so if you do the math, you'll see that we might cross $10 million in expenses. We got $13 million in the bank. That's pretty good. In addition, we expect to get another $1.5 million or so in tax revenues. So we're in great shape to be able to continue to try to support the community in the way it deserves in terms of health care. And so I think we should feel comfortable about where we stand. That pretty much concludes my report.
That's a great report. We like that. Executive Director, Anne Marie.
Okay, in my written report, I just want to highlight a couple of things. The auditors did send to Alan and I today the draft of our annual audit, which they will present to you next month at our March regular meeting. We are reviewing that, looking at the management discussion and analysis, and we'll complete that for them, and those should be out to you prior to next month's meeting. A couple of pieces of legislation that I also mentioned in my report have gained support, I guess, and are ready for the governor and to be passed. Just a couple that will impact us, although very slightly, and probably not you as much as the things that we do in and through the office. So those have to do with special districts, that some ADA compliance that we will have to do on our website. So in the event that makes it all the way through, it has been through all committees and is awaiting pass or fail through the legislature at their final session. Local government fiscal transparency, again, is some of the notices and things that we have to do through our office. That one is not all the way there, but close. And then there is a hospital district bill, which again is more for redevelopment districts than it is for hospital districts. So I'm not sure why it's called hospital districts, but they mention as in the piece of legislation that it is more for redevelopment districts or community districts than it is for our hospital districts. But I just wanted you to be aware of those pieces that are out there.
It's mainly reporting issues.
Yes. Yes, the ethics, there is an ethics one that has come up the last 2 sessions that died before getting to the governor's desk, but that one is making it through all of the, looks like it's positive to come through, so that will involve a 4-hour ethics training for all elected officials, so we would be a part of that as well if that is passed. So, but again, no harm in everyone doing that. That's right. That's right. That's right. And then to your point about the Up Center for the Treasure Coast Community Health Clinic, Vicki did say this morning at the Together for Health group that they saw 13 patients yesterday. They've only been open for, this is week number 2. Yeah, so they have seen 6+ each day at that same-day clinic. So there's a lot happening at the UP Center, so I think it's really a positive thing for the community, so that's it. Yep.
They also, on Wednesdays now, they're taking appointments for it, but they're doing behavioral health on Wednesdays now. They're bringing in their behavioral health person, so
Yes, and they will connect.
positive.
The other thing we talked about at Together for Health this morning was that the UP Center is open, or the Member Share Grocery is open on Saturdays, but no other services are happening and available there. So Anne Marie McChrystal and I were there this morning and Anne Marie made the suggestion that is if there's some way that we can communicate to people where they should go for those services that are coming out. Yeah, so that if they should need something on Saturday, where those are. So we're talking about making flyers and putting those flyers in a, I guess on the wall. They have a bulletin board, community bulletin board, that varying pieces of information
They
can
do have
be.
a check-in center
Mhm.
they could check with, so
Right.
they could go somewhere else.
We had a noontime meeting for the health, I don't even know what they call it, but it has to do with the UP Center as well. And
Okay.
Vicki was there and she talked about that. So they are actually getting a laminated thing to put outside for the hours and all of that
Right.
stuff.
Okay,
So-
good.
She said you were very helpful this morning, Amber.
Oh, I'm so glad. Was I there? You were there.
Okay. Anything else?
That's it.
Okay, good. We'll move into our funded agencies report. So first we have Hope for Families. Diana?
Well, thank you. Thank you for having me, and thank you for what you have done so far. The mission of the Hope for Families is to transform families from homelessness into a sustainable, permanent housing by providing safe shelter, food, and supportive services. Now, what I want to say, without going into the report that you have been handed, is that we are about education, and we're about educating our clients so that when they leave us, they can sustain what is happening with them, with all aspects of their life, not just financial, but health and mental health and behavioral health. And that has always been the issue, is trying to get them the services that they need. By providing us with our client-patient navigator, because that's what we call her, no, it's a new position and it's a developing position, but since November, we have served 122 clients through the shelter. When they came in, I think the best number is, when you look at the numbers, is our first goal was, of course, to get them primary physicians, because they're notorious for using the emergency room, and they have no primary physician to follow up with. When they came in, we had 52% of them with primary care physicians, and we're at 84%. And I can tell you, of those 122, some of them were still in the process of getting connected. So that, to me, is one of the biggest goals that we have achieved very, very quickly. And they are starting to use those primary care physicians. They're not, I don't think, we may have had one or two of our clients going to the emergency room, and I think it was probably with their children, in the middle of the night kind of thing. We do track all of our children. Our children are required to come in with health records, so we monitor that. And we monitor whether they're up to date, when immunizations are due, and if they are due, we connect them directly to get those immunizations immediately, because if they're in school, they have 30 days to get all their records and immunizations up to date. But we try to do that before, much before those 30 days are up. Children are a little bit easier, especially once they're in school age, because they're required to have that. And all of our children, all of our clients are required to have immunizations. The problem becomes with the adults. So we also included in the report our intake document. And you'll see all the questions that we ask them. They're related to health, to mental health, to behavioral health. So it's self-reporting, and self-reporting may or may not tell us everything about them. So with self-reporting, we know immediately to get them connected to mental health, behavioral health, or physical health. We don't always know that. And sometimes, as one of my case managers describes it, it's like peeling back an onion. And we meet every week, and if we discover or suspect that someone needs some sort of service, our client-patient navigator will meet with them and work with them to get them into the appropriate settings. So that has been our focus. The transportation, that's one of the metrics we're going to have to follow. Is there are two things that we had to get it off the ground first. It's how many visits have actually taken place, and we will be following that, as well as how many clients have been transported to these meetings. The wonderful thing is there is no excuse anymore. Once they go, once the appointment is there, they are expected to meet that appointment and to follow up. They sign releases to us, so we then require that medical or any behavioral release to come to us so our case managers can follow up with whoever. So that's kind of a general overview. I'm not going to go through the report word for word with you. It was provided to you, but I want to thank you, and be happy to answer any questions.
I have a question.
Sure.
How many families come to you where the children have not been immunized or don't have the immunizations?
Very few.
But there are some, and you
There-
cannot accept those.
We do not accept them, no. Now, if they need the updated immunization and they're willing to get that,
Right.
we bring them in.
I wonder how severe that problem might be in the community, where families do not choose to immunize.
Well, choosing is another thing. Now, that is, there's the religious exemption, which is
Exactly.
in the schools.
Right.
And we will not take them with the religious exemption. We don't have to, and we won't because of our
I
situation.
just wonder what the numbers are. Probably not a lot, but nevertheless, there would be families that would not be,
And I bet we can track that for you.
Is your staff going to take the mental health first aid?
Actually, they have. Yes,
good.
absolutely.
And
Yep. Go ahead.
what portion of the people that you think you need the support that you actually give the support to?
100% of them.
Okay.
It's 100%.
So there isn't families out there waiting to come in to you?
Oh, you mean coming in?
Yeah.
It fluctuates.
Yeah.
In December, we were completely full, and we were turning families away. We don't turn them away, we turn them back to Treasure Coast Homeless Services Council for further assistance. Right now, I think we might have 4 rooms available. They're not open, they're available, and we work to fill those. But we constantly have a waiting list of at least 30 families. And sometimes you'll call them and tell them to come in the next day, and then they don't show up, so then you've got to go to the next one on the list. I'd love for you to listen to my intake case manager as he tries to describe how we try to fill those rooms. And but we take in, and then we determine really based on what is the most need. They have to be literally homeless. That means they're living in their car or living on the street. If they're going to be evicted, they are not literally homeless. If they're sleeping on someone's couch, they are not literally homeless. Once they become homeless, Once they are evicted, we process them right away. But
How many do you, in a room, when you say a room, you have a room available, so what does that entail? Does that,
I'd love for you to come out and see them. The room, we have 21 rooms, but the rooms are about 10 foot by 10 foot. They have 2 sets of bunk beds. It can sleep 4, but if a mother comes in and she has 4 children, they have to make it work. I can't separate them because there is no connection between the doors. If we have a family, a larger family, and there are 2 adults, we can put them into 2 rooms.
I noticed in the data that about half the homeless families that come to you already have a primary care physician. Does that speak to the fact that things were going well and all of a sudden it fell off a cliff?
No, it really has to do with the fact that that 52% are the children, predominantly children. The parents will take their children to a physician because they have to through immunizations and so on. But as adults, they don't go to the doctor. Yeah. And we have, in fact, they're required to do things. And because I meet with the staff every week, and they were telling the story of one of our gentleman residents who was told, you need to go, and here's what you need to do. And he hadn't been to the doctor in so long. And he didn't want to go. He was fearful in going. And this has been able to help us prod them along and hold their hand and say it's very important that you also get the medical care. But they're homeless and they don't have a roof over their head. They have a difficult time trying to feed their children. Taking care of themselves as adults is probably one of the bottom things on their list.
Is the mobile unit coming to your location?
No.
So are most of these families, have they been homeless for a long period of time, or is it they just become?
They're not chronic. They're very, very few. We don't have chronic homeless families. They really aren't chronically homeless. They've gotten themselves into a situation, and especially housing is a real issue here. Yeah. And if they're paying their rent and all of a sudden the landlord raises the rent, they can't afford that increase in rent, they have to go find something else. Well, to find something else, you have to have first, last, and security deposit. They don't have $3,000 put away to do that. So what do? They come to us. We work with them, and especially, once they're employed or if they are employed, they put away 75% of their net income so that they can build that 2 to 3 months rent, and we can start them back into the cycle. They're making, some of them, minimum wage, and trying to support a family with housing and saving money is often very difficult for them. That's why we're very, very intent on the financial literacy piece, but especially the budgeting. They may develop a budget, but they don't know how to work that budget and what they can afford and what they can't afford. And once they can figure that out, and the fact that if you can manage your dollars and you can put a little bit away and you don't cheat on that, you're going to be okay if you stay with it. But that's one of the biggest education pieces that we find is the most impactful for these families.
I have another question. I probably should know the answer to this. Is the Samaritan Center strictly for catastrophic issues for families?
No, Samaritan Center.
I should know that, but.
Samaritan Center I think they have 9 rooms.
Right.
They are more transitional.
Right.
So they will keep them up to 18 months. We are considered an emergency shelter. We bring them in immediately. Samaritan does not. Samaritan does a mental health evaluation. They do several evaluations before they'll bring the family in.
Well, I do know sometimes when there's a fire or something like that, Samaritan will take families in. It has to be family. It can't just be a single person.
Right, and ours has to be a family too. Ours has to be a family. You have to have at least one
I think
child
I
under
need
the
to
age
know
of
a little bit
18.
more about
Yeah.
other, like, you know, what the difference is. I'd
Right.
like to know that. I think.
And we work really closely, like, we have a case right now that I really can't bring in, and so we'll call over to Samaritans, and if we know if Samaritan's gonna take them, we'll take them. And Samaritan knows if we would take them, they would take them. So we
So
work,
you do work together.
absolutely, we work
Which I
together.
think is very important.
Yeah,
in the community.
absolutely, yep.
Okay,
And especially if some of our clients, we feel need a little bit longer time,
yeah,
we'll call over there.
uh-huh. Well, good.
See, working together.
That's right.
That's important. Any other questions? Thank you. Appreciate that.
Thank you.
Well, thank you. Thank you for your support.
Next, we have Tykes and Teens. You don't look like Jeff.
I'm not. Surprise. So, hi, my name's Andrea Greenlee, and I am the School-Based Services Director at Tykes and Teens, and I'm excited to be here and report on our pilot project called CLASS, which stands for Counseling, Learning, and Support Services. So, I'm going to be talking about the period up to the end of December, and we were only able to find one therapist to come on board, and, well, actually, I hired 2 people. But at the beginning, one of them decided that was not the job that she was looking for, and so we were down to 1. So I'll be talking about the schools that we service, which are Citrus Elementary and Glendale Elementary. And some of the actual results and progress, our therapist is able, you guys are supporting us in what normally is considered non-billable services. So our therapist, Irida, is able to go to the schools and observe and intervene when students start having difficulty, which is really helpful to them because they're in the moment and they have an ally, and that person and Irida can help support them identify their feelings, and it comes to a better resolution than might typically happen, which maybe the child is excused from the classroom. But with this, they're building a connection, and they have that support so that maybe they'll start to feel supported in school, which is our ultimate hope, is that school becomes a more positive place for children. And if they feel supported and they feel wanted, then they'll want to come to school and they'll want to learn. And so often with the classrooms that we're specifically dealing with, the emotionally and behaviorally disordered, the kids start feeling bad about themselves and the school setting, and they end up dropping out. And we're hoping at this early stage that we'll be able to change that. I reached out to Dr. Packard, who has a lot of good things to say about the beginning of our project. She feels that the school administrators are in favor of what we're doing, and we have not yet gotten parent feedback because we're just in the process of getting kids on board for the individual counseling, and normally we send out our client satisfaction surveys at the end of treatment. We're also getting ready to survey the schools because we do that annually as well, and those surveys are going out next month. So hopefully when I come back, I'll have good news to share. Let's see. Oh, successes and awards. Let's see, we're coming up on our 12th year of being accredited by the Joint Commission that we expect them any day. We were recently inquired by the Florida Alcohol and Drug Abuse Association. They recognized us because we have an innovative program in Indiantown, our suspension prevention program. They are going to come observe and maybe try to replicate it in other services or other areas. Southeast Florida Behavioral Health Network, one of our major funders, they selected us to pilot the Zero Suicide Initiative, and that's ongoing. And then with the Florida's Council, I've forgotten the name of it, but the umbrella of the Children's Services Council, they highlighted our Little Tykes program and also our trauma-informed care education series. The Little Tykes is in Indian River County, and the trauma-informed care program we're initiating in St. Lucie County. So those are some of our recent accolades. Difficulties, I mentioned hiring 2 people and then 1 dropping off. I'm also, because mental health is the #1 need, and we're surrounded by counties that have included some mental health therapists underneath their umbrella of the school districts, I'm having some difficulty finding qualified staff. They are in huge demand. Thankfully, because of your support, typically I have some difficulty because I'm not able to offer salaried positions from the get-go, but thankfully to you guys, you've helped provide that opportunity, which is wonderful for the kids. So let's see, difficulties hiring. We've had a lot of growth and expanding into 4 counties, and that has presented some difficulties, but we're managing and adding structure to support those changes. And sometimes because schools are such a focus, and recently with the Stoneman-Douglas legislation, it seems like a real hotbed of initiatives. And so I think some of the teachers are kind of confused with all the additional services that are in place. So we're trying to get some clarity on our roles and where we fit into everything. And how we contribute to the needs is the mental health initiative that you mentioned earlier. You know, we're really trying to get in there early and support these children so that they'll learn the skills that they need, parents can go to work like they should, kids enjoy school, and ultimately will graduate and become a gainful member of the society and the community. So that's very long range, but we're hoping we'll get there. Do you have any questions for me?
And do you find the issues, I mean, you're dealing in the elementary schools, but it's 1st through 5th, right?
Yes.
And is it concentrated in any particular grade level, or?
Not that I know of. The EBD classrooms, it's just, we are focusing on that area, but I assume are they in 1 grade, Arlene? They're all, so it's
different.
it's just elementary school
Okay.
in general. So there's not a hotbed grade per se.
Any other questions? Okay, well, thank
Thank
you.
you.
We'll look forward to when you have talked to and you have more data with what's happened this year.
Yes, thank you. And thank
Okay.
you for this opportunity.
Thank you.
Thank you.
Last but not least, substance awareness, Carrie.
Good evening. So I think everybody might know me, but my name is Carrie Lester. I'm the Executive Director at the Substance Awareness Center. And tonight I have with me our Program Director, Irene Cowles, and our Finance and Compliance Officer, Jessica Simmons. And so we're here tonight to just give you an update on the peer services program that we received funding for. And so I just want to start by refreshing your memory really what that program is and what it's about. And I'd be remiss if I didn't mention that the funding really, we're going to get into what the program delivery is and what the outcomes are and what we're achieving with the dollars there. But when I really step back and look, the funding that we're receiving for these peer services is helping us achieve a much bigger goal and picture, and that is really the shift towards a recovery-oriented system of care. And we talk about ROSC and how we need to change our system of care in Florida, and that's really an initiative that's coming from Tallahassee and trickling down. And our ability to have funding for the peer services, that's a core component of recovery-oriented system of care. And so I am appreciative and grateful and really value the importance of these dollars in helping us champion recovery-oriented system of care here in Indian River County. And I was introduced to these concepts a few years ago, and I was at a workshop and I raised my hand and I said I would be a champion for a recovery-oriented system of care because I've been on both the giving and receiving side of services, and so I recognized a need for us to shift in our approach to treating people who are entering into recovery. And We typically stabilize, initiate recovery, and just wait for them to cycle back through. And the recovery-oriented system of care helps us look at prevention, early intervention, and recovery support services all the way through the continuum. And research shows that we get better outcomes that way. And so a core component is the peer, and really placing value and recognizing that peer's lived experience and what they can do to help engage and retain people into recovery. And on the substance abuse side, we have to remember that only 10% of people with a substance use disorder access the specialty care that they need for that disorder. And so the work that our peers can do in outreach and engagement is vital to help people with a brain disease get into the treatment and the recovery that they need. So I thank you for that, and I just wanted to share really briefly that the managing entity was down few weeks ago doing a contract validation at our agency, 2 days of combing through our charts and files. But at the debriefing interview, the one part of the clinical report was they highlighted that there is no doubt that we are providing recovery-oriented services, and that it was very evident through their interviews with clients and staff and reading the charts that we were implementing those principles and being very recovery-oriented in our care. And so, you know, I made that commitment a few years ago that I wanted to make sure that we were doing and moving towards recovery-oriented principles, and it was seen in that contract validation. And again, the dollars that we get that support our peer programs help us do that. We now have 4 trained peers who have gone through a training that helps them use their lived experience to help engage and retain people in treatment, and also provide the recovery support services while they're in our treatment program. And so my hat's off to Irene, our program director, who has really taken some of these principles, taking the initiatives and the training to trickle down into our clinical staff to make sure that we're doing that. And Irene also supervises all the peers that are providing the services for us. And for some people, it really is a shift in thinking and a shift in philosophy. It really is about becoming more person-centered. It's really about looking at barriers and obstacles and removing them. It's about understanding and meeting people where they're at, and embracing multiple pathways to recovery. And so our peers are out there now educating the community and educating the substance abusing population on the multiple pathways to recovery, one of them being medication-assisted treatment. And so I guess without further ado, I'll kind of move into the highlights of what we've done this report period. So our JAL program, we have 2 peers that go into the Indian River County JAL, and it's 10 weeks of programming. And so in this quarter, we provided the 10 weeks, full 10 weeks. We do 2 hours in the morning with the men, 2 hours in the afternoon with the women. And the peers are really reaching out to start to plant seeds of recovery. It's about helping them start to learn and realize what community resources are available. It's about helping them plant the seed to decide, is treatment going to be their path? Is 12-step recovery church? But it's really about, what is your plan going to be and what are you going to do differently? And to really spread the hope that recovery is possible. And you know, my peers humble me, and some of them have been in jail, and that's why they connect so well with the jail population. But they remind me what a miracle it is when people get out of that jail at midnight and are at our door at 8 a.m. saying, what do I need to do next? Or we even have them, you know, and treatment isn't the path that they all choose. Some of them come to our door just to say, thank you, I'm out, I'm doing okay, or I made it, and thank you, and I'm going to try this, but I know you're here too. And you know, understanding what they're up against when they walk out that door to circle back into a life in recovery means a whole lot. So we serve 29 inmates. The jail allows up to 15 men and up to 15 women in each cohort that we do, and they bring the people into the program for us. And in that first report period ending December 31st, 4 of those inmates actually received access to medication-assisted treatment. And so that means in the jail we have a narrow population that we can do because they have to have a release date for us to even really start to take a look at, are we going to provide the medical assisted treatment for them. But of that cohort, 4 either went through the labs, the physical, and or went all the way on to a Vivitrol injection. And just a brief reminder of Vivitrol is a once-a-month injection, and it costs a lot of money. It's about $1,500, and we are able to offer that to people. And in the jail, it's vital, because if they get an injection while they're in jail, when they leave that jail, they have 30 days to make good decisions, because if they try to use opiates, they will not get high. And so the medication-assisted treatment really stabilizes the brain and helps people start to make those good decisions to enter recovery. And so that's pretty exciting, and really our partnership with TCCH and obviously the Indian River County Sheriff's Office makes it possible, but TCCH has been wonderful at coming in and coordinating the medical care for us that we need. The Recovery Assistance Program, so that is the 2 homes that we have. We have one for men and one for women, and our peers manage and operate those homes. They don't live there, so the people who come into our homes have to have some motivation and stabilization to be in that program. But it's often a bridge from jail into our programs. And so our peers really provide recovery support services in those homes, but they're providing safety, structure, accountability, sense of family, fellowship, the keys and the resources that the people are going to need to build a foundation in recovery. So in our recovery assistance program, we can have up to 6 people in each home. We usually keep about 5. This report period, we served 12 residents, and we celebrated 3 successful completions in this 3 months. And so it's always nice to see them transition all the way through. People have an average stay. I used to say 6 to 9 months. It's 9 to 12 months. It's looking more like it's around 6 to 9 months for people more recently. But everyone's just individual. We've had people stay over a year. We don't say you need to leave now because we're recovery oriented, and we meet people where they're at and provide the services that they need. We don't say our program is 28 days. It's what you need. And some people need more, some people need less. The research says you need to engage for a minimum of 3 months to get the benefit of the program, so we ask them to make a minimum of a 3-month commitment. I thought it might be helpful just to see who we're serving in the recovery home, so I pulled a little bit of information. And we had 3 come to us straight from the Indian River County Jail in this report period, and 1 came actually from the St. Lucie County Jail. And we served 2 out of Veterans Treatment Court, 1 out of Mental Health Court, and 6 coming out of residential treatment. Those are really the ideal. The people who have stabilized a little bit in jail or those who have stabilized in residential treatment do really well in our programs because they have a little bit of time and separation from the substance use coming into the home. And so the loss of residential treatment, the loss of Gate Lodge here, has made a difference in referrals into our program. Independence recovery is really where a lot of our people come from. Where is that? That's our New Horizons program. So the measures that we looked at for the recovery assistance program is people maintaining abstinence while they're in treatment and in the program. So 92% maintained abstinence, which is pretty phenomenal. So, and that really equates to 1 person relapsed while they were in our program. And one thing that we really start to look at, and we're talking about in the recovery field, is recovery capital and the increase in recovery capital. So that is really looking at physical needs. You're looking at physical capital. We're looking at human capital. We're looking at relationships. We're looking at spirituality. And so it's an index. You can get a maximum of 75 points on it. And we do it at intake and every 3 months. And so we're looking at gains. And so our people averaged about, it was an average of 26-point increase in capital over the administration of the inventory. 1 person I did highlight, it was interesting, 1 person had a 7-point decrease, but what my peers tell me is they look through the capital, sometimes people come in and they really overrate themselves, and as they start to get well, they kind of realize maybe how sick or how challenged or compromised they were. So we attribute maybe that was somebody who wasn't really seeing the clear picture and maybe is actually getting better, because we only had 2 scales on that 1 person who gave themselves a decrease. And so we use that again as a talking point and setting goals, being very person-centered about where do you want to move on increasing your capital. Employment. So a big goal of the program is really getting employed, stabilizing a bit financially, and getting into safe, stable housing. And so employment's a big thing. 66% looks low to me, but we had 3 successful completers, and 1 of them was on disability. But we still think work is a big piece of it. So even when they're disabled, our program requires volunteer, and they do a lot of hours over at United Against Poverty. And this resident, even though disabled, did maintain volunteer position even in transitioning out of our house. So if we want to count volunteer as work, we'd have 100%.
Yeah, we do.
And then housing, 100% of our people did, those 3 people who successfully completed transitioned into stable, safe housing. And I just want to highlight, I don't know if I'm out of time here, I went through what the inmates fill out, and what we do really just for an accountability piece is document kind of what the peers have done in the jail and in the group. But I looked at the sheets of paper the inmates turn in. They just kind of identify an insight they gained or a goal or a plan that they're going to make for the week, which is nice in holding them accountable. But as I looked at each one, handwritten one, I noticed comments off to the sides of the paper. A lot of some of these are really unsolicited comments that people wrote on the back of the sheet or around the side of the comment. And a couple of things consistently rung true to me, which was the importance of people caring, coming in and caring, the hope that they were given. And a lot of inmates commented on, now they know that they were so grateful to know that there was resources that if they chose, now they know what is out there for them to access if they choose recovery. So that was really nice to see. And I think every week there was a thank you written somewhere off to the side. And so the gratitude and the appreciation, but it kind of surprised me to see that they took the time to kind of unsolicited give us a little bit of feedback. So that's in there. I won't read them all to you. And then we always try to just collect little things from our clients who are going through our program. So I added a few of those, and I won't read them to you, but I encourage you, if you have any questions or want to come visit our homes or our program, I'm happy to share that. If you want to meet our peers who are doing this great work, to me, it's so exciting for me to see where we've been able to come and what we've been able to grow into in meeting the demands and the needs here in our county. So I thank you for your support. You're helping us make a big difference, and you're helping us move and shift into a recovery-oriented system of care. So thank you. Oh, yeah. What we do at intake is our peer actually does an orientation. So we go through the handbook, and that's where we do a lot of our communicable disease education. We've added Hep A education for the health department, but we'll put in the qualification. So we'll make sure everyone knows how to qualify. If our peer can assist getting qualification for hospital district funding, we'll just add that to our orientation process. So that'll be every adult that receives treatment services at our agency, which ends up being over 200 a year. Any questions?
No, but next time, maybe the gals can say something too, to add to. I'm sure they've got a, see, there she is. She's ready to go.
Hi, I'm Irene Caldwells. I just want to thank you so much because you change lives. And I don't know that you see the lives that you change. Just one young gentleman came to us, 19 years old, mental health court. Mom pulled him out of school in high school because he was so anxious and nervous, and he started using alcohol to black out, snorting Xanax, smoking marijuana daily, and no dad in the picture. And he'd been through mental health court and was facing serious jail time. Without the recovery home and a place for him to get away from everybody, kind of controlling family, controlling girlfriends and all that, and get away and be in a safe house with men, and our peer support kind of guided him and educated him to know what's it like to go from being basically 13 years old to a man at 19. And watching this man grow just brings tears to my eyes. He's successful, he's employed, he's doing a very good job, and he's also looking at the ladder saying, I'm employed now, but this is my current job. I need education because I'm going to go to the next tier. So none of that would have happened without you, so thank you.
Good. And what about you?
I'm here for numbers. I'm the numbers lady.
I know what questions you guys have.
We wanted to be so prepared for you, but last fiscal year, this program ran a deficit of over $64,000. And when we sat down to do the budget for this coming fiscal year, Carrie and I we were struggling to even know if this was a program we could continue. The need is there. We knew the need was there. We just didn't know how we were going to continue to pay our peers. And so the funds that you're providing, we're still going to run a deficit, and we know it, and we've taken steps to make sure that that's covered. But with the help of your funds, we were able to continue this program.
And where is the deficit going to come from?
We do drug testing for the community, for employers in Indian River County. We have really done a hard push to try to bring in some more of those funds that are unrestricted dollars to really, for this program. I mean, this is the only program we have right now that we are expecting a deficit at the end of the year. And so we're trying to bring in additional revenue in other areas so that we can continue.
It's the one program that's consistently run a deficit for us, but we've been really committed to doing, and I think the value's there, and we're starting, now that we're able to show and share the stories of it, I've been able to get out and ask for some more funding for it.
Good for you. Good. Very good report. You are doing a great job in the community, so keep it up.
Thank you.
Thank you.
Any other
Thank you.
questions?
Yes.
Thank you so much. Appreciate it, guys. Any unfinished business with anybody? Any new business? Any other business?
Any monkey business?
Really, I know, a lot of business. Any public comment? Okay. Hearing none, we are adjourned. Thank you so much.
Thank you.